I am going to talk on non-pneumatic anti-shock garment in obstetrical hemorrhage. It's not uncommon to find certain articles on this of use of non-pneumatic anti-shock garment, but usually it is used for transporting the patient of hemorrhage from primary center to a tertiary center. But we thought of utilizing the same in the labor ward of a tertiary hospital itself, and that is the difference between from any other study. Now, we all are aware that the WHO has last reported the approximate incidence of 810 women dying every day of a preventable cause of pregnancy and childbirth. And 94% of these occur in the low and lower middle income countries. I happen to be belonging to one. Global incidence of the severe PPH is approximately 11%, but it accounts for 35% of the total maternal mortalities. And unfortunately, India contributes to 1/5 of these. Out of 80 deaths, that means 16 happen in India. And we state that one mother dies of PPH every 4th minute at an international level. And it would, be adequate to say that it is not a death of a mother alone. It is the devastation of the whole family. So what I'm actually stating is that by the end of this lecture, we have approximately 5 families devastated somewhere. As it comes to the postpartum hemorrhage, the incidence of this is variable from 2 to 6%, depending on what is the mode of delivery. It could be as low as 2 to 4% for normal vaginal delivery, but a little higher for cesarean sections. The commonest cause remains atonicity. The incidence would be relatively higher amongst anemics, pre-eclamptics because of their hemoconcentration, heart disease, etc. Since the destabilization of these patients is much faster with even lesser amount of blood loss. And we all are aware that amniotic fluid embolism can raise oozes for anyone in any labor room. The tertiary level hospitals are unfortunately hub of the cohort of high-risk population, which includes the anemics, pre-eclamptics, heart disease disorders. And therefore, we are all aware that we have to be really apt with the management of postpartum hemorrhage, which is quick diagnosis, resuscitation, use of uterotonics, blood and blood components, surgical interventions, which are primary in traumatic, but may be required even in atonic causes. And many low social developing countries with low resources lack these facilities in many good delivery centers. And PPH is a common indication of morbidity or mortality in the referrals from the primary centers to tertiary level centers because of the late referrals. So it is quite evident that time frame for safe referral and effective care is a significant cause and technique to decrease the morbidity and mortality. So let's just revise in one slide the pathophysiology of hypovolemic shock. So we are all aware that hypovolemia will lead to decreased venous return, decreased preload to the heart, decreased cardiac output and hypotension. And this would lead to perfusion failure and tissue hypoxia. And there is a stage when this can be compensated well. If that does not happen timely, it will lead to organ dysfunctions. And initially it may be reversible, soon may land up in multi-organ failure. And that's the commonest cause of mortality. And let's see where the NAST helps. Now, the NAST will help us here because we understand that decreased preload is the first primary step for ending up in the multi-organ failure. And let's use the NAST at this stage. So before we go into the use, let's see what it is. It's a very simple neoprene Velcro device, which is cheap, lightweight, easy to apply and use, and it diverts blood from the non-vital organs to the vital organs, will temporarily stabilize the bleeding, and is primarily, as I stated earlier, is meant for transporting patients to higher centers. And we used it in a different kind of a setup, but for similar indications. Now, it consists of these segments, which are applied on the lower limb, at the level of the pelvis, and at the level of the abdominal cavity. But what I just wanted everyone to notice is that there is something called as aortic pall, which is in the abdominal segment. And this is what will compress upon the aorta, as we will see in the next few slides. Now, this is how it is applied. The female is made to lie with her spine parallel to this yellow line on the NAST garment. She's placed like this, and then we start applying the segments from below upwards. So this is around the ankle, then the second one, and subsequently we go on to apply the next and next onwards. We need to keep the knee free so that the patient can walk around and bend her knees. So we had placed the women on the top of the level of the lowest rib. Sequentially, we were segmenting up tightly around the ankle and calf and on both the sides. And then leaving the knee joints free for easy mobility. The applications are made around the thigh. Then fourth and fifth is the pelvic part with lower edge at the level of the pubic bone. And thereafter, the last ones where the pressure ball will directly be lying over the umbilicus and hence cause aortic compression. The only precaution which you need to take is that the abdominal segment should not be held too tight so that there is no restriction of the breathing and the person is comfortable. And this is how, after the application of all the segments, the women and the garment will look like. Just ensure that the patient is comfortable and she's normally breathing. If the patient is having any itch or feeling hot, all we can do is reduce the temperature outside. Now, how it works? This is when the application of NAST is helpful, because most of the blood in the obstetrical cases is lost through either the vagina outside or into the abdominal cavity. And this decreases the flow to the upper part of the body because we have the loss from here. Now, this is when the application of the garment is there. There is a circumferential compression on all the vessels and the blood is going to be diverted from the lower limbs. And we know all the vital organs are in the upper part of the body. That means liver, heart, brain, etc. Now, of course, and kidneys. And this aortic compression, which the ball we were talking about, will increase the resistance index of the internal iliac artery, which has already been proven in many studies by its Doppler studies. Now, this will decrease the blood flow and stabilize the blood pressure. It takes less than 1 minute to apply the garment in trained hands, and this would further decrease or delay the deterioration of the hemorrhage, which is crucial to prevent the morbidity and mortality. Certain prerequisites, we are using it for transfer to a higher authority, would be to take an informed consent for this use, place an indwelling catheter with the Eurosac in situ, then document on the referral all the details which you think are going to be important for the institute where she's going to be received. So therefore, what drugs, what fluids, and what all interventions have been done must be informed to the institute where she's going to be referred. She can be referred with a vaginal pack in cases of traumatic cause of BPH. She can be transferred and should ideally be transferred with oxygen and IV fluids on flow. She should be accompanied by a nurse or a doctor if it is being used for referral. Now, the main advantages of NAST or a life wrap, as it is called, is that it permits flexibility, continues to allow you to use uterine massage to decrease the blood flow further. And of course, you can continue to use the uterotonics or any other intervention which you require. The beauty is that you can, because of the knee joints being free, The patient can be permitted a lithotomy position, and you can see that in this position, any vaginal intervention which you wanted to do an examination or repairs or an manual removal of placenta, bimanual compression, dilatation and curettage, or any for that matter, any surgical intervention could be still, carried on. Keeping the segment 1, 2, and 3 in situ, even an abdominal surgery or a laparotomy can be done. You could probably, just before cleaning, you could take off these segments, conduct the surgery, and do it in a little quicker way, and replace the segments once the surgery is over. She can be given any kind of Trendelenburg positions or any other position which is required with the 3 segments in situ. Now, the special situations that may command some attention are obese patients, or where the woman is shorter in stature, etc. And when defecation or something happens to replace the segment. Now, most important probably the part of NAST use is the removal criteria. And what is advocated is that it should never be removed in haste. We can begin the removal once the bleeding is well controlled and the patient is stable for at least 2 hours. The bleeding should decrease for less than 50 ml per hour. The pulse should be relatively stable and at least 100 beats per minute. And the blood pressure should have been stabilized to at least more than 100 millimeters systolic. The hemoglobin, I'm quite sure by the time the blood transfusions are given, would have been ensured to be risen to more than 7 grams. Patient would ideally by now be patient conscious and fully aware. Before we start the stepwise segment removal, it is in the same direction in which it is applied. That means from below upwards. But what is to be taken care of is that after removal of every segment, you need to wait for about 15 minutes. We have made it a principle of rule of 20. Check for the pulse and BP. If the blood pressure is increasing by, decreased by 20 millimeters, or the pulse has increased by 20, and we wait for about 20 minutes, reapply the segment. If the patient was stable for about 20 minutes, go on to remove the second segment, and so on. We do the same at every step and gradually remove the segments one by one. In case the patient was unstable or the bleeding recurs, it can be reapplied and further management be thought of. Now, the relative contraindications are very few, except in the patients of cardiac failure or with pre-existing mitral stenosis and pulmonary edema, where the venous return increase could cause them in going into failure. Abdominal evisceration and open pelvic fractures for patients who are not non-pregnant, and advanced pregnancy with the live fetus, because this is going to compromise the vascular supply. However, if it's the patient's life which is more important, and that case, even the fetus could be compromised. The principle that is to be observed is that only one person should apply the NAST. Two people can apply the lower segment simultaneously, so to be quick, but the upper segment should be applied by only one person so that we do not have excessive force. And one must keep a monitor on the urine output so as to know that the patient is actually getting stabler. And we should ensure the airway protection and prevent aspiration under a critical nursing care, which is mandatory for any other patient of shock also. Easy to clean, only with the running water. Just dip it in the disinfectant, dry it and pack it in a clean plastic bag and store it at a visible site, which is displayed prominently for an easy access for anybody who requires it in future. Now, when we started using it in our hospital settings, the methodology remained the same. Most of the common causes of the hemorrhage or hemorrhagic shock we found was ectopic pregnancy or antepartum hemorrhage, postpartum hemorrhage, inversions, or something which is happening soon after the delivery within the institute, or in cases of placenta previa. Now, the parameters which we prefer to study was the time vitals at admissions, 30 minutes after the application of the NST, and during transport either to the ICU or to the hospital, intraoperative, postoperatively, and at the time of the NAST removal. The parameters which have been dependent upon in this study are the shock index, which is heart rate divided by the systolic blood pressure, normal value, varying from 0.7 to 0.9, the mean arterial pressure being around 60, and we studied the modified shock index, the normal value of which is supposed to be less than 1.3. This is the shock index divided by mean arterial pressure. So if we have these two values, the modified shock index can be already easy to calculate. We also found out or studied the time which was required for issuing the blood and the amount of blood that was required, blood or blood components for that matter, total duration of the use of inotropes and the garment, the kind of surgical intervention that was required or medical management which was required, and the survival status with duration of hospital stay as well as intensive care unit stay if she required one, versus the duration in some few patients of, where NST was not used when this garment was not available with us, were also studied to just make the results more prominent. So this is a very crowded slide, but the parameters which, as I've stated already, were 3, and they were studied at admission after the application of NAST for 30 minutes and whatsoever intervention was planned. Now, this is the mean which I wanted to reveal, that at admission, if the shock index was 1.3, 30 minutes after the application of NAST, and of course, since resuscitation is part and parcel of management of any hemorrhagic shock, and it would be unethical not to give this, so therefore, these combined together, the shock index was brought down to 0.9 within 30 minutes of application of NAST or whatever resuscitation measures were used. The mean arterial pressure, you can see the rise within 30 minutes by about 10 millimeters, and the mean modified shock index was similarly reduced. Now, the secondary comparisons which were made or studies were the quantity of the inotropes used or the duration of inotropes required, use of blood and blood components, the amount of stay in the ICU or HDU, that is high density unit, any kind of intervention, whether medical or surgical, and the survival status, eventually after the use of the NAST and the resuscitation or the surgical intervention, whatever was given. Now, what we found that NAST has a great impact on the quantity and duration of use of inotropes. Requirement of blood and blood products and ICU and HDU stay is decreased. The kind of medical and surgical intervention can really vary. The need for the dialysis for patients going into renal failure, castrating surgeries like cesarean hysterectomies are lesser often required. Less drastic interventions suffices to bring out the patients from shocks, and eventually, therefore, it prevents a lot of morbidity and mortality. Apart from this above, the kind of relaxation it gives to the persons who are managing the patients, you are no more under stress. You are peaceful. You can afford to call your senior faculty, get assistance of any kind, wait for the cross-matching, proper cross-matching of the blood. It is so relieving for the residents that after the first application of NAST, if this garment was under wash and there was another patient who required, my residents were cross with me that why we don't have two. So eventually they are now addicted to the use of NAST, and we have now 2 garments in our labor room for use so that no patient is denied the use of NAST. Now, the gross observation, as I stated, was the decreased requirement of inotropes intensive care unit, With NAST application, the requirement was maximum for 6 hours, and the lower doses were required when compared to the data which we retrospectively studied from the files when the NAST garment was not available with us. Now, the duration of ICU has been really grossly reduced to almost 1 most of the time. And we have had only 1 maternal mortality, that too in a patient who was received in an irreversible stage already. We knew that we will not be able to salvage, yet we gave the benefit of NAST to this patient. Contrarily, when the garment was not in use, the NAST was required for more often. The stay was in the HDO or ICU was for almost 5 days. Higher doses of inotropes were required. The ICU stays were prolonged and the outcome therefore were poorer. In one patient, we in fact required a dialysis. The urine output is very well maintained when the NAST is in application, because we know that the blood has now been diverted to the kidneys. So even in irreversible states of shock, the management is much easier when the NAST is applied. So without the use of NAST, we had one patient who went into renal failure and of course required dialysis for quite some time before she could be recouped. In another patient with the hemodialysis, this patient required probably for almost a month, and she required the hospital stay because she was from a very far away place. So I just wanted to show you these graphs which we drew for the shock index, and you would see that the patients when received at admission, the shock index is very high, and just with the application of NAST, you would find that the shock index just comes down. Of course, when I'm stating it is NAST application, it also means that the resuscitative measures were being simultaneously used. And then, of course, we expect that when intraoperative or postoperatively, when the measures have already been taken, shock index is likely to improve. So this is the part which we are concerned more, conscious about with the use of NAST. These are, of course, the graphs, similar graphs of many other patients. And so we see that NAST application does bring, this is the mean, mean of all the patients, and we see that there was an improvement in the shock index in 52% of the patients, and in the antepartum hemorrhage in 46% of the patients. SI without the use of NAST will improve because you are giving other resuscitative measures, but then you can see that it is only to the tune of about 12%, and in APH to the tune of 17%. So this is just a graphical representation of what I have already stated, and you can probably see the differences in the shock index and ICU states and inotrope use and blood products with and without NAST. Now this is the graphical representation of the blue line showing the shock index where the NAST has been used, and the orange line showing where NAST has not been used. This is an artifact because 0 means no NAST has been applied. So one will have to imagine that this orange line without the NAST is at a higher level. And from 1.7, you can see that the average improvement would be much lower when compared to the blue line, which is showing a drastic improvement with whatever is happening, whether it is the use of NAST, post-operative or post-medical therapy. So this is the comparison in ruptured ectopic pregnancies. This was in PPH, this in post-abortal bleeding, and this for the cases of postpartum hemorrhage. So in all the cases of hemorrhagic shock, we find that the application of NAST brings an improvement in the shock index within the first 30 minutes. So I conclude that NAST is cheap, cost-effective, reusable garment, easy to apply, easy to clean and maintain, prevents or delays the hemorrhage, thus stabilizes shock, delays conversion of irreversible shock to reversible ones, reversible to irreversible state. It decreases the blood flow, blood loss by at least 50 to 73%, thus improving the morbidity to the tune of 50 to 55%, as well as preventing mortality. The time gain by the application of NAST is very relieving for the doctors managing the patient. It permits proper cross-matching, obviates the need for any rapid spin technique to bring the patient out of shock by giving the blood and blood products by rapid spin technique, which has become almost obsolete since we have started using the NAST. The quantity and the quality of blood, because it is a quicker intervention, so that the requirement has decreased, and therefore we assume that any reactions, associated blood reactions, we have already taken care of by reducing the amount of quantity and quality of blood required. Now, probably this decreases the ICU and HDU stay, and therefore the expenditure to both the hospital and the patient, and the risk associated with prolonged hospital stays. No risk of overinflation and excessive pressure is there, because this garment is non-inflatable with no tubing, pumps and valves or gauzes. So it is not a tourniquet. It is to be used like a garment for only compressing the vessels of the lower limbs. So while the use of NAST is primarily promoted for transport of hemorrhagic patients from one center to the other, with constraints from human resources and insufficient resources in developing countries, we promote and we advocate that it should be used in every tertiary level hospital also, where it has not been used earlier. In fact, the moment you observe that the patient is going into shock, it could be put to use. We have started using it even for prophylactic, like surgeries where we anticipate a lot of blood loss, like secondary abdominal pregnancy, etc. Because there you can just lay open the garment on the OT table, start the surgery, and in case the patient is going into shock and advocated by the anesthetist, apply the garments and close the patient, and you could still take the patients for uterine artery embolization, or if you want to refer to a still higher center, you could probably do that. So with that, I conclude that I think it is not only important to save life of a patient, but every drop of blood, specifically in developing countries where even the availability of blood and blood components is not that easy. So with that, I would conclude my talk.